Welcome, and thank you for joining us for Part 3 of Surgery Department's How to Survive and Thrive webinar series, titled Simple Steps to Improve Patient Satisfaction in Your Perioperative Areas. During this last session, we will show you how improving patient satisfaction can make you more viable in an increasingly competitive surgery market, how to focus on the 4 key components that contribute to improved HCAHPS scores, and examine the entire perioperative experience from the patient's point of view. In order to keep background noise to a minimum, everyone will be muted. We encourage your questions at any time throughout the demonstration. Just type your question in the chat box and we'll answer any questions at the end of the session. Our presenter today will be Stephanie Randa. Stephanie is the Vice President of Analytical Solutions at Your Perioperative Areas. She received her MBA and her MHA from the University of St. Francis. She is also certified as a Lean Six Sigma Black Belt. As a registered nurse, Stephanie has a membership in AORN, ANA, and TNA, and is also certified by the Certified Nursing Operation Room Program. Stephanie, thank you for being here today, and we look forward to the presentation.
Thank you, Lauren. This webinar is something that I always enjoy talking about because it's really pretty simple steps. It doesn't cost a lot to really improve patient satisfaction and really make a difference. It's really important to set the stage for the surgical patients and the family because you're really the doorway of them coming into your operating room. So here's just going to be a few suggestions that hopefully will make a difference for you all and improve your overall satisfaction scores. So our objectives today are really to define why it's important to focus on that patient satisfaction in the perioperative setting, describe what the patients expect from their hospital stay, and then provide some examples of bottlenecks and solutions that result in that patient satisfaction. So let's just start with our first polling question. Is your department involved in patient satisfaction? I say that because a lot of times your HCAHPS scores are really just focused on your inpatient data. So a lot of times you don't have direct responsibility for improving them. But a lot of times your patients may come into your operating room and then are part of the inpatient experience. So we'll just give you all a second here. Many times the patient experience really could be really costing you. The advisory board estimates about $700,000 is lost in new patient revenue due to bad word of mouth. And now with the social media, Facebook, instant messaging, those bad experiences can go out pretty quickly. 84% of healthcare leaders rank patient experience among their top priorities. And so that's really, this patient experience is listed as #1 as the top 3 priorities for the next 3 years. So the HCAHPS scores really become that benchmark for measuring the patient satisfaction. So as we're moving from a fee for service to a pay for performance, this is really tied to the quality of care. So hospitals with the higher quality of care will receive those reimbursement incentives. So you really want to look at those quality measures because they're broken out. 70% is really focused on patient outcomes, but 30% is on that patient satisfaction. With the increasing competitive markets in our surgery areas, we have to make sure that that perioperative experience from the patient's point of view is really perfect for them. So one of the hospitals that I was at really started to focus on feeling that wait times was really the most important thing that they could be taking care of. But to find out, we really wanted to drill into the data and really to look at what was the most important and kind of tackle it in that direction. One of the things that we ended up doing was discovering that the most important, and that's on the left-hand side, was that to make sure that the staff cared. The doctor's concern for comfort for the patient was also very important. How the doctor explained different procedures or a patient's condition was really important to patients. The nurse keeping the patient informed, information about delays, family and friends kept informed, and nurses attended to needs. A lot of those things are what can be done within that perioperative setting. Then you have pain control, the nurse listen, and respect for privacy. And then on the other end, what things are less important? Wait times before they were seen by a doctor, that wasn't as important. The courtesy of a nurse, the nurse concerns for privacy, the staff permitted family and friends to be with the patient, cleanliness, that was always really surprising to me. Helpfulness for the first person asking about the condition. Wait times before treatment, before the treatment, and then wait times, the wait area comfort. So waiting really became less important than we really thought. So what we did, we really piloted an initiative where everybody in the perioperative area was taught to communicate with each patient during their wait. So for example, even the janitor that was sweeping the hallways near the patient might say, I know you've probably been here a long time. Is there anything we could get for you? And the patient experience score suddenly went up. So that was something very simple that we could do, but again, we wanted to drill down into the data to make sure that we were focusing on the right thing. When really looking at creating a service area of excellence, there were three things that really came up for us, and that was respect. And so respect is important to patients because they want providers to treat them like individuals and engage with them personally. So this really goes against what we typically in healthcare do and what we've learned, because we've really been taught to be objective and unemotional. For the patients, though, this personal contact and connection is important because the patients tend to feel that when the providers connect with them, they make fewer mistakes. I think the other piece of this is respect for each other and respect for other departments. Many times as I'm doing observations in hospitals, you don't necessarily see that. Maybe there's finger pointing from one department to another. If there's rework, sometimes an employee may say, well, this is, that other department just doesn't know how to do this, so they have to do the rework. So they kind of give excuses for that. So you really have to be careful about how we talk about each other's departments. And then communication between caregivers. Since patients aren't medical experts and really don't know what questions we're going to ask, and we're asking them really to keep them safe, it seems to them that we're really not talking to each other, and so that perceived lack of communication between providers really leads to patients believe that they're receiving substandard care. And you could hear this many times, when patients are saying, gee, I've answered these questions before, don't you all talk? So you want to make sure that they understand before you start asking them questions, to let them know that you may have heard these questions before, but the reason we're doing this is to make sure that we're providing safe care. And so that sets the stage for that patient. The other thing really that is becoming more prevalent is really around happy providers. And so what this means is if your staff are dissatisfied or they're unhappy about something, that rolls over to your patient satisfaction as well. So for every 1% increase in employee engagement, the organization's overall hospital HCAHPS ratings increased by 33%. So that's really important. So if staff, we want to make sure that the staff know this as well. So as we talked about, communication is really important, particularly as you see in the perioperative area. So there may be two areas that an OR director really wants to kind of focus on. Communication must be timely. So if you are waiting to talk to a patient, you want to make sure that, or the case has started or there's a delay, you want to make sure that that information comes to them and they don't have to ask for that. You know, why aren't I in surgery when I was scheduled at 7:30? So the best thing to do as far as what we're seeing is the better performing ORs, they really start communicating at the time of scheduling. So they communicate that there may be multiple phone calls, and that's okay as long as the patient's expecting that. And so if the patient really doesn't expect to have these phone calls, they may get frustrated again with the hospital and the overall communication. I know as I was doing an observation in a hospital, I noticed that a patient's daughter was getting very frustrated, and she was in the waiting room, and you could see the frustration on her face. And I said, well, you know, tell me about your experience so far in this surgery area. And she said, well, my mother got several phone calls from the hospital, but nobody would tell us, you know, what department they were from or what phone number to call, and so that caused her to be very anxious and very concerned that maybe something was wrong. So we got here earlier just in case we had to do something different. So what had happened was that now because of HIPAA, you can't necessarily explain that, you know, why you're calling for a particular patient, but it is important to at least give your name and a phone number so they know who to call. And again, something very simple could lead to a lot of stress for that particular patient and their families. So sometimes patients may receive multiple phone calls, and that may be for scheduling. They may have to reschedule. Maybe there's a conflict, and so you want to make a scheduling change. The pre-admission testing department, a lot of times they will call to schedule a patient to come in, and then you have somebody from your financial services or your registration department that's calling. And again, the patients don't necessarily know that they're going to get multiple phone calls. They think that they've already scheduled their procedure and everything's already taken care of. So one of the things that is important to send that consistent message is to perhaps have a handbook, a brochure, and to really help the office, the scheduling office from your physicians know to inform the patients that they may get a phone call from somebody from scheduling. They may get somebody from pre-admission testing or financial services. The other thing that is helpful is if you teach your staff in these departments to let them know that they may get another phone call from somebody else if they haven't already called them. Again, it looks like we're being consistent. It looks like we're talking with each other. In some areas, they found that the registration area and the pre-admission testing area actually had more things in common than not, and so they actually put them on the same floor or in close proximity, because many times the patients come through and talk to somebody as far as registration, and then there's the pre-admission testing area. So again, sending that one consistent message is really what's important. You want to cover patient expectations, and that's really the basics. Where do they need to go on the day of surgery? What do they need to bring? How long before they move between the different phases of care? Do they even know they're going to move from different phases of care? Perhaps there's a patient handbook. Can you put this online? Can you give it to the patient or have the surgery office give this to the patient? And what's the expectation for pain? I know myself, having a surgical procedure, and my husband having a surgical procedure, even though I'm part of the healthcare field, I wasn't really necessarily aware of what that particular hospital was going to do. So again, it creates some angst and concern if you've not given enough information. then target your waiting times. Again, I know it may not be necessarily high on your list as far as what the patient thinks, but waiting can lead to patient dissatisfaction. I think a lot of times, given where we are, we can expect waiting. In some areas, we could tolerate that wait. If you go to a big box store like a Costco or a Walmart, waiting is not a problem because you're anticipating that, and you also know that your costs are lower because of that. Maybe you've been put out a little bit more. But when a patient comes to a hospital, they don't necessarily expect to wait, and they don't necessarily understand why there's delays. So you want to start looking at your wait times throughout that perioperative process, whether it's pre-admission testing, registration, the preoperative holding area, the PACU. And if the patient has to wait, communicate that need. Make sure that you're letting them know along the way that you're sorry that they had to wait and what the reason for the wait is, and then typically they can understand that. So some points of when you want to communicate. When the surgery's begun. Many times a patient is moved from perhaps a preoperative area to a holding room, and so then their loved ones may not really understand that they haven't gone to surgery yet. So they think they may have left surgery, for surgery to actually begin, much earlier than that it really occurred. And then when is the surgery complete? I know that a lot of times I get a lot of pushback as we're working with staff because they're concerned that the physician won't necessarily like that. I think you have to have those discussions with the physician to let them know why you're communicating and what you're communicating to those patients. When is the surgeon going to communicate to the patient's family? Because you, as the nurse that's in the operating room, you want to let that patient's family know the surgeon will be communicating perhaps by phone, it could be in person after the surgery, it could be several hours after the surgery. So again, setting those expectations are really important. And then let them know when the patient has gone to the PACU and is stable. When they're ready, perhaps you have family visiting during that time. Let them know when the patient is ready for discharge to the room or to the home. Again, sometimes that's not necessarily communicated, and the family may have to go and inquire about them, and only to find out maybe they've been sent to their room. And then if there's going to be a follow-up phone call, let them know what to expect, because again, you don't want that to be a surprise. And if you have electronic family boards, communication boards, don't use that as an excuse not to communicate to families. Again, sometimes the families could really appreciate the phone call, and if they have any questions, then that's the opportunity they may have to talk to the nurse. So don't just rely on those electronic boards. So let's have another polling question. So what is the percentage of your first case on time starts? And we'll show you a little bit. We're going to be talking about bottlenecks, and so that's why we're asking this question. So is it less than 50%? Is it greater than 60%? Greater than 75%? Or no idea? Okay, so this is just an example of a common bottleneck that I see as I go into hospitals. So I'm going to set the stage for you here. This is a typical waiting area. You have Dr. Red, his first patient is here, Dr. Red's second patient is here, and his fourth patient is here. Dr. Green's first patient is then next, and Dr. Blue's patient, Dr. Green's first patient is here, and Dr. Blue's first patient is here. This is your preoperative area, and these patients are arriving and they're being prepped on a first come, first served basis. And again, typically the patients have gone to the registration area, and then maybe they are either escorted or they're brought back to perhaps a room, or they're brought to another waiting area, and the nurse is made aware that they are here. So we have 3 nurses on duty today, and so Dr. Red's first patient is, let me see if we could use a pointer here. So Dr. Red's first patient is here, and so they're brought to the preoperative area, and so we have the first nurse here. Dr. Red's second patient is here because Dr. Red, he likes to tell all his patients to get here at 5:30 in the morning, no matter what time that they're scheduled. And then Dr. Red's fourth patient, and we're going to put him here, and the third nurse is now going to take care of him. But so now we have ORs ready for Dr. Red, who's going to go into OR number 1, and we have Dr. Green is going to go into OR number 2, and then OR 3 is there for Dr. Blue. So as you could imagine, as the nurses are taking care of the patient, you know which doctor is going to be on time, and that's going to be Dr. Red. Okay, so here's Dr. Red, and he's going to be happy about the whole thing because all his patients are lined up. But unfortunately, Dr. Green, his patient he's going to have to wait, so he's maybe not on time, and then same with Dr. Blue. So as you can see, how you bring your patients in, you may want to stage them, you may want to triage them as the order that they're supposed to be coming in, because again, you don't want to just add additional nursing staff because of the way Dr. Red schedules his patients or how you bring them in. You could let Dr. Red continue to schedule that way, you just don't bring them in the order. So you want all your first patients in the rooms so they could best be served. Here's another common bottleneck, and so one of the things that may occur is you're not necessarily looking at the schedule prior to the day of surgery to try to improve that patient flow. So you want to make sure, again, typically what may occur is all your patients and families arrive at that 5:30 mark. And again, that just causes problems for your preoperative area. Your staff then start coming in at, let's say, 6:30 or 6:45. And so they're beginning to get their first cases started of the day. Anesthesia arrives maybe a little later, around 7 o'clock, and then your physician is arriving at 7:15. So again, having everybody coming in at different times isn't necessarily, as far as your staff coming in and your physicians, that's not necessarily the way to improve throughput as well. Oops. So, if we change the process, if we prioritize those patients and have them arrive in the appropriate times, again, you have pre-op those patients, you know what patients may take more time, and so you may need them to come in maybe a little early, but otherwise you don't want all your patients coming in. So you want to make sure that you're talking to the patients and letting them know what time to come in. And so as far as when the staff arrive, perhaps they're arriving and anesthesia is arriving at the same time. So again, we have no anesthesia delays. If we have a patient that needs additional time, anesthesia is there to deal with them. And then maybe your physician, again, they're not coming in at the very last minute, but then it gives us all to focus on those first cases. Patient, you have to remember that with patient satisfaction, referrals are really important for revenue generation for every hospital. You want to maintain your loyal customer base. And again, if a patient has a positive experience in this highly competitive market, they're going to come back to your hospital because they know how you treated them. Your success really depends on attracting and retaining those patients. You want to make sure that in the world of electronic media, their good experience, really that word spreads quickly. So in summary, you want to create an expectation of the staff to be courteous and respectful, not only of the patients but of each other. You want to script any difficult conversation. So if you do have to let a patient know that they may have to wait, what does that conversation sound like? You want to do any recovery that is necessarily. You want to make sure that the communication is timely. And again, when people have to wait, when they're not sure what is going on, you want to make sure that that communication occurs. You want to set that realistic expectation for the patient and their family. Again, that's the best way to do that is through communication. And then be prepared for service recovery. Things happen, so you want to make sure that you want to listen to a patient for their concerns, and you want to apologize. I always encourage the manager to go to that patient and explain the problem, and let the family know that they want to learn from the mistakes and they're sorry that it happened. And sometimes simple words really make a difference. So that's the end of our webinar today. Hopefully you've come away with some good ideas, and thank you very much.
Thank you, Stephanie. That was very interesting. It's interesting to hear about how human touch really does make all the impact in the world when it comes to HCAHPS scores on both the patient and caregiver side. When you have a question, it has to do with follow-up materials. We will be sending out both the webinar recording and a link to the slide deck in the next couple of days, so keep your eye out for those. We really appreciate your time today. If you have any questions, please feel free to reach out to us at info@yourcareuniverse.com, and we hope you have a wonderful afternoon. Thank you.